basically, before I go to the talk, I just want to bring three terms to the audience. One is monotherapy, which means you're treating with one drug. One is combination therapy, which means that you are treating with two drugs. And one is sequential therapy, where once your one drug is finished, you are following it up with the next drug. Why we need a sequential therapy? Because there is something called as a memory effect, which is there with bisphosphonates, which is not there with the other newer drugs which have come. So let's talk about teriparatide. It's a savior in a lot of situations, but what happens with teriparatide is this, that you see the rise in the BMD mass, but once you discontinue it and you do not follow the treatment, you see the negative BMD sort of correlation which is going down, you start losing the mass. And this is the change in BMD in spine versus the hip. So the above one, you see the spine, when you stop at 30 months, you see the dip which is happening. It is less in hip, and everything, whatever happens, the spine is the first to respond because it is highly metabolic cancellous bone. So the response is good in the spine, the bad response is even worse in the spine. I'll bring you to the second study, which is the data switch study, where basically denosumab and teriparatide were studied in combination. So you see, if you give teriparatide, follow it up with denosumab, you get good result. You give both, which is the combination therapy, follow it up with denosumab, you get even better. And denosumab followed by teriparatide is the worst. So you go into negative thing. Have a look at this graph. In lumbar spine, the green is the combo therapy and blue is the teriparatide followed by denosumab. So it does not make a very, very big difference in spine. But yes, in hip and distal radius, combination therapy is much, much better. And a lot of people ask that if you're having a spine problem, why don't you start the combination begin with only? So the answer is that in spine, it does not make a very huge difference. So you want to save more years to give longer therapy after 10 years. Yes, in desperate situations, we try everything, whatever is have in our hands. So what happens if we stop denosumab abruptly? This is a 60-year-old female who was on denosumab, suddenly decided to stop the treatment, and she had consecutive 12 level fractures in the spine. If you see this marrow edema in T1, you see this, all of these end plates had marrow edema, and she had sort of end plate fractures. And this is the reason for that is that when you stop denosumab, you see the sudden spike in these bone catabolic markers, which is the CTX or the NTX, and they sort of tend to settle down at 46 months. So between the first 2 years, when you stop the therapy, there is a very, very high chance of developing a fracture. And if you restart them, they again come back. But we have to be careful in these patients. And whenever we start on denosumab, we always counsel the patients that do not stop it abruptly without counseling, without consulting me. Or if you are having a delay in taking the denosumab, it's not available, you're outside, keep me informed so that sort of we can change the date earlier rather than giving it later. So there is a lot of literature on these fractures which are there once you suddenly discontinue the long-term therapy, and that is the reason that even denosumab, once you follow it up with teriparatide, needs a subsequent sequential therapy. So another lot of literature about it. So the vertebral fracture rate increases 6-fold when you stop the denosumab versus if you keep on continuing it. And the current regime supports that whenever you want to stop denosumab, if you take a decision to stop denosumab, you have to give a year of oral bisphosphonate, or even IV is good, because that lady, we treated her with zolindronate for a year and now she is settled with that. Or in such situation, if you have propensity, you can restart denosumab also, that works better. Weaning of denosumab is other thing. If you are giving it, you may have to wean it slowly over a period of time, like increase the frequency of the, sort of increase the duration of giving denosumab and then sort of stop it. Drug holidays are something which cannot be safely initiated in denosumab, so we need to give something to follow it up with. And even if on bisphosphonate, whenever you give a drug holiday, like after 4 years or 5 years, you decide that you want to stop it, do not take the patients off the daily vitamin D, which is around 1200 international units, and daily calcium, 800 to 1000 milligram per day. You do not deprive them of this calcium and vitamin D. It's very essential to keep it sort of continued. So what's the ideal sequence? The ideal sequence is that if the patient's clinical condition allows and there is no contraindication, we start teriparatide in desperate situations or in severe osteoporosis, especially surgical patients, either in mono or a combi therapy. We follow it up with denosumab because it is better than bisphosphonates in turning the bone turnover markers as well as BMD correlations. If you have to stop it, denosumab, you give a year of bisphosphonates and then you stop it. And drug holiday for bisphosphonate, you continue with vitamin D and calcium and think of restarting it in a clinical situation. That just leaves us with one last question to which I still don't have the answer, is that we give denosumab in stage 4 CKD, but when stage 5 CKD comes, there is no clinical evidence to what you should treat. So we don't know what to do in these situations. I usually refer these patients to endocrinologists. But there are some nephrologists who are using it off the label in stage 5 also. There is increased risk of hypocalcemia, but this is still a question which needs to be answered.
Thank you
very much.
Agnivesh.